Welcome back to Hot Mess Espresso, guys. This is actually kind of a redo because technology happens, but we have technically new to you, not so new to me, but we have Shannon Saur-Zavala on the podcast today. How are you, Shannon?
I'm doing well, Heather. Thank you so much for having me back.
Yeah, no, I'm very excited. We just kind of like talked off camera about how we're both like definitely grateful for this redo for several reasons. So I came across you because you are actually a therapist that specializes in treating and researching borderline personality disorder,
That's right.
which was beyond a perfect fit for this.
Mhm.
So, I guess my first question is what got you like into all of that? Because that's a very niche topic to get into.
Yeah, absolutely. So a couple things. I kind of knew early on that I wanted to be in a field where I was making a difference or helping people. Wasn't totally sure what that would look like. I majored in psychology in college, and then in the year between grad school and undergrad, I worked at a residential treatment program, and a lot of the patients had BPD, and I hadn't learned a ton about BPD in college. And so really was like very interested in the experiences that the people I was working with had and how basically like how their lives had unfolded such that they were in a residential treatment program. And was doing like some like therapy-esque, except I had no training and no credentials. And so that's kind of another reason I wanted to go on for more school, because I felt like people really deserve to have expert care and not some random recently graduated undergrad
Right.
providing their mental health care. So when I applied to grad school, I was really interested in learning dialectical behavior therapy, or DBT. And the place where I went to graduate school, University of Kentucky, had a full model DBT program. So those were some of my first clinical experiences. And I know we're going to get into this later when we talk about kind of like myth busting around BPD, but
Mhm.
I think there's like the way that I think in training we talk about treating folks with BPD as if like, well, that's for when you're more senior, after you have more experience. They're too severe. And for me, I think that's where I started. And so it never was a thing I had to like graduate to. And so that's kind
Mhm.
of my model for just like working with people. And of course, like I mean, I have found the experience is really rewarding.
Right.
So that's how I kind of got into like BPD. And then in terms of like doing research, which is probably like 80% of my time, and then maybe 20% doing actual therapy, again, going back to like, how can I do the greatest good? And so I know that we have treatments that work for BPD, like DBT, but they're long term and intensive. Not everybody with BPD needs that level of care. And so the idea is like, well, maybe there's a place to refine our treatments so that more people can have access to them.
So, like, what were some of the most surprising things that you kind of realized once you started your research?
Yeah. So I think for me, understanding like really just how treatable borderline personality disorder is maybe the biggest surprise, right? So, especially having gotten my clinical training in DBT, where it's like you're trying to get people to commit to a year of treatment, individual and group. And, that was in like 2005. So we really were like pushing, it needs to be a year and we need to get a commitment. Whereas now I think like they've done studies with shorter courses, 6 months courses of DBT.
Mhm.
And so, the sort of like prevailing notion was that this is a disorder that needs really intensive care. And my research has really shown that, in 18 sessions, people are experiencing a great deal of relief.
Yeah, that's huge because back when I was in treatment and I'm still technically in treatment because you're kind of always in some form of treatment when it comes to it. Um there was no cure.
Mhm.
It's, this god awful thing. It's a therapist's worst nightmare. I know in some states, and this is back when I looked a few months ago, I may stand corrected now, but when I looked, because I had seen something on TikTok and I was like, there's no way it's actually. In certain states with assisted suicide, borderline is one of the disorders that
Okay.
are allowed to be on there because the suffering is so great and there's no like cure technically. And it's like, that's just so, it's so disheartening as somebody that has dealt with it when you see stats like that you're just like, wow, okay, so like, so it's so nice to see that there's actually something out there.
Yeah, yeah, absolutely. So, like, if you look at longitudinal data, so there's this researcher at McLean Hospital called Mary Zanarini, and she
Mm-hmm.
has been tracking people with BPD for over 20 years at this point, and people that started out like hospitalized. Oh my gosh, sorry.
No, you're good.
Do not
I'm
disturb.
honestly surprised I would like remember to put my phone on D&D.
um, so she studies people that had been hospitalized for BPD like over 20 years ago, and she's followed them all of this time. And basically, what she finds is that almost everybody recovers and recovers quickly. And in fact, some of the symptoms that remit the fastest are the riskier ones, right? So the more impulsive things, risk of suicide goes down quite a bit as
Mm-hmm.
people really like age out of those symptoms. And that's without treatment. I mean, some people had treatment in the study, but like a lot of people didn't. And you still see like kind of the natural course of the disorder. And then when you add treatment into the mix, people can see that relief, within a year.
Yeah. Did you notice that like in your studies that people that were removed from certain situations that were kind of compounding on the trauma or the risky behavior, once they were kind of removed out of that they actually recovered quicker?
Yeah, right. So we teach people new ways to manage their emotions, new ways to interact with people, or kind of like be a little bit more vulnerable so that they can learn about trust. And we teach people to kind of like delay gratification if they are more on the impulsive side of things. And like you can't really safely practice being vulnerable if you're still in an unsafe spot, right? Like
Yep.
and a lot of times when I talk to my patients, right, like, pushing people away or, lashing out, right? Like, I mean, those served a purpose probably at some point in your life and were adaptive. They kept you safe and they protected you. The problem is
Absolutely.
when you generalize those behaviors to people that
Yeah.
are safe or you're out of that situation anymore, that's what makes it hard to kind of learn that was like sort of maybe the unsafe situation is not necessarily like what everybody is like.
I can completely understand that. I know that I talked to my therapist like once I was in a safer environment with my relationship with my now ex-husband. I was like, why do I feel like I'm getting worse? And they were like, you're actually able to unpack everything,
Mm-hmm.
like all the fight or flight, like you're actually able to unpack. You're safe now. And sometimes
Yeah.
that actually makes it worse. Was that kind of your experience with your patients too? Like, especially on the residential where they were in a safe area, did you notice that there was like a spike of just like, ah, before they were like,
Yeah.
oh, okay, this is what it's supposed to feel like?
Yeah. So the residential program was for me like 20 years ago. So I
Oh,
actually can't remember. It's like a cautionary tale around getting old. But yeah, like in the outpatient work that
you
we're
don't look
doing.
it. Because
Oh, thank you.
you're like 20 years. I'm like, were you 5?
Nope. So in our treatment studies, usually we're doing things where we push people out of their comfort zones, right? And that's
Mm-hmm.
definitely, and we kind of do like truth in advertising therapy where it's like, yeah, it might get a little bit worse before it gets better because like maybe you've been engaging in strategies to push away emotions, right, to resist feeling. And so we're going to try to counter that in treatment. And like, not gonna lie, that's gonna be really hard. That sucks. Same deal with like being honest or being vulnerable in a relationship. Like that is terrifying and like really necessary to build new beliefs about what you can count on other people for.
Right. No, I love that. If I say one more time. But so we had talked back in February or March, I think.
Mhm.
So, and I know you're actively in research for how to, treat this and yada, yada, yada. What have you been up to in the last 6 or so months?
Yeah, yeah. So I'll give like a little bit of a preamble to maybe orient people,
Yeah.
but basically like we're in the middle of what we consider like a shift in how we think about diagnosing personality disorders like in the field of psychology. So, any listeners that have BPD know that in our DSM, like our book of disorders, there's 9
Mm-hmm.
symptoms and you have to have 5 of them basically to like meet criteria for BPD. And that means that there are 256 different combinations of those symptoms that can result in a BPD diagnosis. And 2 people with the same diagnosis can share only one symptom in common and still both have BPD. So I always say, if
Mm-hmm.
you've met somebody with BPD, you've met somebody with BPD, right? You can't really
Yeah.
make these generalizations. Um, the other thing that's kind of stigmatizing about like yes, no, you have BPD is that it doesn't really like reflect clinical reality where it's like, these things are on a continuum, right? It's not yes, you have it or no, you don't. It's like, on a continuum. So there's been a big push in my field to think about like what are some of the risk factors that we can think about on these continua or dimensions. And so the new way that people have been approaching BPD is to think about it as like some personality trait vulnerabilities. And so
Ooh.
BPD is kind of constructed as like high neuroticism, which is basically just, I mean, it's not the best word, but it basically just means like
No.
tend to feel emotions really strongly. Cool, me too. Um, Low agreeableness. And so that also doesn't sound great, but basically what it means is difficulty trusting other people because you've been hurt in the past.
Mm-hmm.
And then low conscientiousness, which basically just means impulsive. And so those are dimensions that each person can like be at a different place on it. So I would say I'm pretty neurotic, but I am like bottom of the barrel low in or like high in conscientiousness. So I'm not risk taking at all. But it's a better way to get like more sort of like detail about individual people and what might be driving their symptoms. And so that's like the long preamble to say that we've developed a treatment that instead of targeting those 9 symptoms of BPD, we're actually targeting those 3 risk factors. We call the treatment COMPASS, which stands for Cognitive Behavioral Modules for Personality Symptoms. And so essentially, we've been testing it. It's 18 sessions long, and everybody right now, the way that we've tested it, gets skills for neuroticism, skills for low agreeableness, and skills for low conscientiousness. But the idea is that we'd be able to personalize care based on what is driving a particular patient's symptoms. So if you take like substance use, for instance, sometimes people use substances because it dampens negative emotions, right? I don't want to feel. That's a neuroticism process. Big emotions, don't like them. Sometimes people use substances because it feels great. That's like a disinhibition or low conscientiousness process. And so the idea is that like if you try to treat somebody who's pushing away their emotions with an impulsivity treatment, it's not going to work, right? We have to know why a person is engaging in their behaviors. And so that's kind of the premise beside the treatment. So we've been testing it and we've been writing up, we're done testing it. We have 100 people with BPD that have participated in the study. And we know that BPD Compass leads to like statistically large reductions in BPD that are comparable to a year of DBT. We know that BPD Compass also leads to significant reductions in generalized anxiety, social anxiety, panic disorder, OCD, PTSD, and substance use disorder. Because again, we're not targeting BPD, we're targeting these risk factors, and the risk factors are the same for all of those disorders. So you
Yeah.
see what we call transdiagnostic results.
No, I absolutely love that. And to kind of um point like add a point onto what you were saying with it being generalized. Earlier this season I actually had my friend and I that is borderline sat down and we literally went through, I think it was like an hour long that we went through on the 9 characteristics and we were like, yeah, I struggled with this. I struggled with this too, but it was more friends. Mine was more romantic relation. It was
Mm-hmm.
really interesting to see how similar but different we were. So I absolutely love how yours is very, very customized and like broken down. Like
Thank you.
the ADHD sub point in me is just like, ooh, it's like, you know, this and then like it's great.
Mhm.
But that also gives me like so much hope because I went through the year of DBT and I'm gonna tell you right now, DBT is very effective, but it is overwhelming as hell because
Yeah.
I did all technically 4 modules. They kind of broke one of the modules up into 2 because it was so overwhelming. And then you get this like sheet where you're supposed to track your stuff, and it's like 100 of these like
Mhm.
different like skills, and I would literally stare at these and be like, I don't even know where to start. Like I would use half of them way later in life and realize that like, yeah, I can use radical acceptance on like
Yeah.
the XYZ, but it was really overwhelming. And I'm not knocking DBT because again, DBT is incredibly effective. It really
Yeah,
is.
and also, like,
It's
groundbreaking, right? Like, there was
yeah,
nothing before that, right? And in
yeah,
1993, Marcia was like, "Let's treat people that, other researchers and treaters are ignoring." And so I think that's huge. But right, and it works great for some people and is not the right fit for other people.
yeah. Like it was just more overwhelming when I was learning about it. And I'm like, I'm never going to use this. And then I use it more in daily life because like subconsciously it's in the back of my head now that I've learned about them. And I'm like, oh, that's what
Mhm.
that is. Like when I'm like, it is what it is. Like that's radical acceptance. And people
Right.
are like, oh, you know, but I also love how your treatment very much humanizes people because I think that's what a lot of BPD treatment was missing. They were just like, oh, we need to treat the symptoms. And then once the symptoms are like sort of treated, like fly birdie fly. And I feel
Yeah.
like from what you've described to me, it's very customized to each person. And I mean
Yeah.
it's already stigmatized because it's a personality disorder. So people are like, "Oh, something's wrong with you as like a whole person." And it's like, yeah, the people around me that clearly traumatized me to the point where I have a whole thing. So shush.
Yeah.
But you know, I love it. So
Yeah.
now that trials are done, what's the next step?
Yeah, so we are doing a couple studies now to really like optimize the delivery. So we know that when you give all 18 sessions and all skills to all people, that on average everybody gets better. But we want to make sure that we're presenting the material in the most optimized way. So we have a big grant now from the National Institute of Mental Health. Like we're talking like millions. I'm feeling very like proud of that, and that's
I'm
a
so
development
proud
cycle.
of you. That's amazing.
Yeah, and it's great because NIH doesn't fund a ton of research on BPD. So this is a huge study, a 200-person clinical trial where we're just going to give people the modules of Compass that map onto their personality elevations. And so kind of seeing like if we can personalize care and get more efficient and more robust results.
Now, just to clarify, this is on top of the prior 100-person clinical trial, correct?
Correct. Yep. So we'll be
Okay.
treating another 200 folks, but
I
giving a personalized set of modules versus everybody gets the same,
got it.
shell of a treatment.
I do remember the scientific method from like second grade. So that's why I
Yeah.
was like, I'm pretty sure they have to like, okay, we have a hypothesis. Now we have to like retest it.
Yeah.
So, how this is just kind of like a really random weird question, but like how close are you to getting something like peer reviewed or are you already there?
Yeah. So in terms of peer review, so at the original trial comparing 50 people, 25 that got Compass and 25 that were on like the wait list slash delayed treatment condition, that's published, that's out. Basically showing these effects. We just actually like I don't know, like last week or the week before, had a paper accepted on those comorbidity outcomes that I was telling you about. So, the effect of Compass on anxiety disorders, PTSD, OCD, depression. So that one just came out. And those are empirical articles that are, very cut and dried factual.
Right.
Um, one of the things that is really important to me though is like disseminating the treatment, right? Like I didn't do this so that I could write articles for other academics to read. Like I want to get this treatment out into the world. I've had talks with publishers, and there's a couple routes that you can go. I really want to publish through this series called Treatments That Work because it has a lot of credibility.
Mm-hmm.
And it has a lot of credibility because they require really, really strong evidence, like research evidence, before they'll publish it. And because
Right.
we're still collecting those data, we want to be really sure that this is as optimized as possible. I make like just a PDF of the workbook available on my website so that therapists and clients can just access it.
Yeah, this is like huge. To backtrack a little bit to the comorbidity, um,
Yeah.
I think you and I talked about this on the episode that will never ever air. But are you seeing a lot of either comorbidity or misdiagnosis of both BPD and ADHD? Because I know that they're like as a core, they're relatively similar, but obviously there's like a couple things that are just BPD, a couple things that are just ADHD. But like I do my best to kind of keep up with the like latest with all of that, but I
Mhm.
do know that either people are getting genuinely genuinely is not the right word, but that's the word we're going with. Um diagnosed with both like I was. Or they're like, no, it wasn't BPD, it was actually ADHD because we realized after like treatment that I was missing XYZ from BPD or whatever. Are you noticing more of a correlation with ADHD and BPD, or is like does it kind of get wrapped into, the anxiety disorders and stuff like that?
So that is like such a good question because when people are experiencing symptoms of anxiety, of BPD, of ADHD, it's kind of hard to know what's driving the inattention, right? Because
Mm-hmm.
like being really anxious makes it pretty tough to pay attention. And so in some ways you have to like kind of provide treatment and see, so like if you were to take like a stimulant medication, like that's not going to address your BPD, but we would get to
Mm-hmm.
see what part of your experience was inattention, right? Whereas like, a stimulant medicine, if you have interpersonal difficulties or big emotions, that's not like a stimulant medicine isn't going to really touch that. So in some ways, it's like you kind of have to treat and see what gets better as like a trial and error
Mm-hmm.
kind of thing.
No, that makes complete
Yeah.
sense. I will say that ADHD meds, um, lately, all they do is give me panic attacks. So we're on nothing right
Yeah.
now,
Yeah.
which is like super
Oh,
fun. But thankfully they've done a lot of research, and like legal doses of medicinal mushrooms are very much available. Every time I say mushrooms, I'm like, not the ones that make you like go on a fun trip, like the actual ones that are at like the nature store. Those are
like the
great.
line. Yeah.
Yes, like I love lion's mane and cordyceps. I will say that is my stuff.
Mhm. Yeah,
Um,
I mean, like I am kind of like take a pragmatic approach to treatment,
mhm.
right? And so like if it works and it's not causing, so like it's number one, does it work? And then number two, does it have unintended consequences that will bite you in
Right.
the ass later?
Yeah, literally. Because I will say, Adderall and Concerta, like they worked, but it was not worth the panic attacks. I'm like,
Yeah.
nope. I don't want to be in constant fight or flight mode. Like I literally did 7 years of therapy to get out of this.
I mean,
I'm not
fair.
going back.
To go back to
Yeah.
that you mentioned around how like the treatment compass like humanizes people. One of the things that we put in the treatment that like I don't know, it doesn't really surprise me in hindsight, but like I wasn't necessarily expecting was that we start the treatment with values identification. So
Ooh.
so instead of starting the treatment with like, what are all your problems? What are your goals related to your problems? We start the treatment by basically being like, okay, like, what kind of person do you want to be like as a daughter? Like, what are your values? What do you want to be like as a friend? Like, pie in the sky, like aspirational. What do you want to be like as a worker? And so we get the person to really, it actually helps with some of the identity stuff, but like we get the person to reflect on what's important to them. And then we use that as a motivator for change. I think like I don't want to be in a position as a therapist to put my values on my client, right? One of my colleagues
Right.
actually studies BPD in sexual and gender minorities, and BPD tends to be over-diagnosed in those communities because some of the impulsive behaviors, particularly like risky sex, are actually like normative to those communities, right? So you're like over pathologizing. So I don't want to have a person in treatment and be like, you should have less casual sex, right? Like that's
Right.
putting my value on them. If that's like in line with their values, like, and not causing harm, like you go. Right. And so that's why we really like starting with values, because it helps us really identify like what's important to the client and use that as a motivator for them to think about changing, not being like, well, these are your symptoms, so we need to bring them down.
Well, and it's to kind of uh add to what you were saying, like a lot of things when it comes to like drug use, alcohol use, like risky, that's like almost like a coming of age in your 20s.
Right.
So it's got to make it harder to diagnose. Like, is it BPD or are you just like 23 and having like a little too good of a time here? That kind
Mm-hmm.
of thing.
Yeah. Yeah. No, exactly. And I think that's how, I mean, there's some research evidence suggesting that people getting early treatment, like in adolescence, can be really helpful. And it is like so tough to identify in adolescence. Like you can, they
Hmm.
can in studies, right? Because like some of the like emotion dysregulation and the identity stuff that's normative in your like later teens is like intensified in people that end up having BPD. But, man, like can you imagine like being a parent and like you have a teenager and it's like hard to know, like, is this, should I be seeking help for this, or is this like what they're supposed to be
Right.
doing?
Yeah. You had said something about identity
Mm-hmm.
earlier. I know for like me personally, that's something I still kind of struggle with is like who I who I am.
Mm-hmm.
Um I'm mostly confident in like who I am and like where I'm at and what I bring to the table. But like did you, I mean it's going to be different for everyone, but was that one of the more common things in your treatment observations that you noticed a lot of people really struggled with just as a more
Yeah.
broad.
So I think like the most frequent symptom that people endorse is mood lability, right? So just like ups and
Right.
downs in emotions, strong
Mhm.
emotions. So that's going to be your most common one. And then typically like after the anger one, no. So like I actually hate that anger is one of the DSM criteria for BPD, because there's so much data that shows that the number one emotion that people with BPD experience is anxiety. It's not anger. So I think that is stigmatizing and I don't like it. But anyway, so anger is sort of like 50-50, but strong
Right.
emotions, yes. Then the kind of the second most endorsed, I would say, is like interpersonal stress, right? So you can really think about, I mean, I think about BPD as like more similar to an anxiety disorder than other personality disorders. And it's
I
like
would 100%
anxiety.
agree with you.
Yeah, yeah, and it's like anxiety. It's not social anxiety, right? So it's not fear of being evaluated by others. It's anxiety about like, closeness in relationships. It's anxiety about, yeah, like about relationships.
Yeah.
Well, I was just going to say, to kind of close the loop on your comment about identity, then like behavioral dysregulation, so like impulsivity, suicidality, identity, emptiness, those you are kind of interchangeable. Those are the ones I think that vary a lot more across people. But for
Yeah.
for people that do endorse that symptom, it is really distressing.
I'm kind of wondering if anger is the more like number one symptom because anger is usually more outward where anxiety is definitely inward. And
Yeah.
obviously you wouldn't know anxiety is inward unless you're actually doing your research.
Yeah. So I was just going to say too, like, I mean, you think about too, like the history of diagnosis, and like BPD is disproportionately diagnosed in women, even though prevalence rates, when you look at like epidemiological studies, is even. And then you think about who developed the diagnostic criteria, and like that was in 1980, and like you know was there even a woman on the personality disorders DSM work group? Probably not, right? And so like what do a bunch of dudes in the early 80s think is problematic? Angry women.
Yeah.
Right. And
Oh,
so you
you're
can
just
see how
being
that would go.
dramatic.
Yeah, right. And how that would get like codified into
Mm-hmm.
our book of disorders.
Men, we love them.
The worst. No, just kidding. I love mine.
I like mine, but men. But just to kind of we kind of touched on it. We've kind of we've basically touched on it like this entire episode. But what are some of the when you went into it? And obviously, like you went into it with more of an open mind and let's see what I can debunk on this. But what were some of the like most surprising myths about BPD that you were able to kind of debunk when you like really dove into it?
Yeah, that people with BPD are manipulative and that they are difficult to work with. I have not found that really at all. So the party line on like manipulativeness is that like that because people with BPD have strong emotions and because they do, depending on the person, struggle with suicidality, that people in their lives feel kind of like jerked around to try and like, provide support. But that like manipulation kind of presupposes that the person is doing it on purpose, that they have like, ulterior motives. And that just has not been my experience at all. I have largely found people with BPD that I have worked with to be so grateful that, someone's willing to work with them, honestly, which is so ridiculous to me. Really like the hardest working group of clients. I mean, and really cool and have so many strengths in a lot of ways. I mean, they really, really care how they are affecting other people, and I think those are all those interpersonal myths about what it's like to work with somebody. Like you're gonna get yelled at by your client. I mean, I don't know. I think in like 20 years of doing this, I have really not had that experience.
Right. I think to touch on the manipulation too, it's a lot of the times it comes off as manipulative, but it's just like what we were taught.
Yeah.
Like that
Yeah.
was the survival mode. You had to learn how to work the system to feel any sort of safety.
Yeah.
And it
Absolutely.
unfortunately trickles into healthy people that you're around. And they're like, you're being manipulative. And I'm like, I swear to God, I'm not.
Yeah, yeah. No, totally, right? Like, and so in Linehan's like kind of early writings about some of this, she talks about how like invalidation, right? And so, often people are getting punished or ignored for emotional expressions unless it is like a huge explosion that they can't be ignored, And so what
Mm-hmm.
does that teach somebody as they're growing up about how to get their needs met?
It's not healthy.
No, no. I mean, and that I think like, when clients come to treatment, they know that those patterns aren't like working anymore, but they don't know what to do instead. And basically, this is like from DBT too, but I think is really apt here is that like these aren't like just like deficits that can't be overcome. They're like to the person, they're skills deficits, right? Like,
Right.
if you are being punished for your emotional expressions and only being like listened to when you have a big reward or like you have a big kind of like outburst, then probably those people that like your caregivers or your friends or whoever you're with, like they're not modeling like how to ask for something that you need, and like those things can be
Right.
taught. It's just that like when you get to be an adult, it's like there's no one actively teaching you unless you go to therapy for it.
Right. Exactly. And I think the hardest part about getting treatment is that your brain's wired all sorts of wrong. And it's literally like physically wired wrong. And then you have to try and physically rewire it. And that is the hardest part is unlearning things that are subconsciously ingrained in your system.
Yeah.
And then having to be like, yeah, just toss it all away. And here's how we're going to do it now. And it's like, uh,
Yeah. Yeah. I mean, I think too, that's like part of the reason why I really like working with BPD patients. Like, I mean, I know it feels like cliche to be like, you're so brave, but it's like, man, like you've been through a lot and here you are still trying. And like, I mean, respect, honestly. Like, I think that's really boss and like why I think I really just like feel for my clients because it's like you're still here, you're still fighting, and that's pretty rad.
Yeah, I feel like getting your foot in the door to get treatment is the first big step, but then it's just that first few months where you're just like, I have to relearn everything. That is, it gets easier over time because muscle memory, basically. But even then, you still have some issues.
Yeah.
So when they're no longer in the borderline criteria, what is like, how do we help support people that still have some BPD symptoms? Because obviously you don't lose all 5 to 9 characteristics. So, how do you continue to support patients after they no longer are technically borderline and they're,
Mhm.
what is it, CPTSD? Is that the new classification after
So
borderline?
in so CPTSD is actually not in like the DSM, but it's in ICD-11, which is like the World Health Organization's classification
Got
system.
it.
Frankly, I think that there has not been enough research on CPTSD to really like,
Agreed.
yeah. But okay, but the question is, what do you do after you maybe
Yeah, like
don't
how
like,
do you
you
continue to
don't,
support people?
yeah. Yeah. Well, so one of the reasons I really love targeting like personality traits or vulnerabilities instead of like, yes, no, you have BPD is because everybody has a personality, right? Like, and
Right.
so, there's no like magic threshold that you cross over to say, like, you know, oh, like this is no longer a problem for me, right? Like everything's a
Right.
matter of degree. And so I think like it allows people to kind of like, people to kind of cultivate the type of person that they want to be. So one of the things that I've been working on too, like kind of outside of my BPD work, is kind of an extension of some of this, like, developing the traits that will help serve you in your life for everybody, right? Because I think like have we all have growth opportunities
Right.
and in some ways I think that that's like maybe takes away some of the stigma. I know you mentioned like how the term personality disorder really sucks, right? Like your
Mm-hmm.
personality is disordered, like that is just that's how we use words to be um, you know, crappy to people. But I
Right.
do think like everybody has a personality. And, you can think about like you actually, if you wanted to actually look at the data, you could like think about like depression and anxiety as personality disorders too. They're disorders of
Mm-hmm.
high neuroticism. And there really aren't those distinctions. And so I think like helping people identify the goals that they still have and like how can we use the skills that you have to move towards your values is like ongoing.
For sure. Um, so one quick question before we wrap it. Um,
Yeah.
your manual. So what is it and where can we find it?
Yeah. So the manual that we've developed is like a client workbook. So basically like when our study therapists are providing the treatment, they'll like describe the skills and then they'll assign homework, right? So like read this chapter, it'll go over everything that we talked about and then there'll be like a exercise for you to do to
Mm-hmm.
practice the skill. And I don't think that treatments that work should be behind a paywall. And so I just, you go to my website and if you put in your email address, which is literally just because I want to keep track of like how many people are downloading it because it makes me feel good. Um,
Valid.
you yeah, that I'll it'll get emailed to you, the PDF of the workbook. So it's great
Perfect.
for therapists that want to provide evidence-based treatment to their clients, and it's great for people because unfortunately we live in a world where sometimes it's hard to find a provider that like takes your insurance or like takes insurance at all.
Yeah.
And so you can use it in a self-help kind of way.
So what is your website?
It is www.personality-compass.com.
And we will
And it's on
definitely
there.
have that linked below. Um, but yeah, Shannon, thank you so much for technically coming back and coming on.
Yeah, of course. Yeah, my pleasure, Heather. I really enjoyed talking to you the first time. I mean, I love um, you know, busting myths about BPD, so I'm glad
Same.
for you to give me the platform to do it.
Oh, absolutely. And it was a perfect fit. And I cannot wait to see where this study goes in a year.
Well, yeah, I will certainly keep in touch and let you know if there's any updates.
All right. Thanks so much again.